Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. Through this channel, we hope to bring you quality education in regional anesthesia. If you like any of our videos, then do remember to click the like and share button. If you are new to our channel, do remember to subscribe so that you can get regular notification of any future uploads. Okay, welcome back. We're going to do a short demonstration. Before I begin this demonstration, I'd like to thank VSonic for supporting this webinar and to bringing it to all of you across the world. How many do we have today, Brian? Okay, about 450 participants. That's quite good. I hope you enjoyed this session. I can bet on you that there are very few sessions you probably have attended that give you so much detail and anatomical facts and sonoanatomical tips and pearls like today. So as I said, all these presentations that we are doing will go up live on the web through our website after the conclusion of the 10th webinar, so which will be in December. So just stay tuned and be a little patient. Okay, so we have a volunteer here who's lying in the lateral position. You could have sat the patient up, but I think for comfort, this is usually what we would choose. And this is the ultrasound system we are using. It is the Labatt VSonic ultrasound system. And this is Daniel. He's going to be helping me. Hi, Daniel. Can we have the linear probe with the wider footprint, the 50 millimeter footprint, please? First, I'm going to use the linear transducer just to show you what it can do and what some of the limitations are. Although it's a higher frequency and you would anticipate higher resolution, yes, it is. But there are some limitations with it, and I will come to that. And as I showed you, that don't underestimate the power of low frequency transducers today. Okay, so we have a low frequency, this is a high frequency linear transducer. It's a broadband transducer which serves 15 to 4 megahertz. So we are going to start from the higher frequency range. And we have used musculoskeletal preset. We have set the scanning depth to, so let me show you what we are doing. Can we go to number 3? So you can see we have set it to about 4 centimeters in 45 millimeters in depth. And this is a rectangular field of view that you can see here. So this is a fascinating ultrasound system because it has a lot of optimizability in quite much like some of the high-end systems that we use in our clinical practice. So having the ability to optimize the ultrasound system is the key to getting good images. So I think today ultrasound has become an integral part of our practice. So if you treat the ultrasound just like a point and shoot camera, then you'll be sorely very disappointed. I think being able to optimize the image is key to getting good ultrasound images. Because if you don't have good ultrasound images, then I think half the battle is lost in most of the cases. When I say optimizability, that means you should be able to choose the right frequency, choose the right depth, choose which most systems allow you. But most systems won't allow you to choose the right focus. They will not allow you to choose the right gray scale map that you may want. You may want to change the dynamic range. How does dynamic range affect the quality of the image? These are some features that I think is vital to understanding how to get a good image. Okay, that's a discussion for another day. So today, as you can see here, Ranjit, my fellow, has very kindly put some landmarks here. These are the oval structures are the spinous processes, and then you have the interspinous spaces in between. So we are going to focus our attention mostly in the mid-thoracic region. But let's come first to try and see if we can identify the ribs, okay, and how to identify a given vertebral level. Now, if you see here, Okay, Daniel, can you increase the depth one notch for me? Keep going. Now see, we are increasing the depth to get to the ribs, okay? The upper ribs are usually deeper here. Now you see that the field of vision is becoming narrower and narrower. So one of the limitations of using a linear transducer when you're scanning at a depth is that your field of vision will become progressively narrower as you go up the spine, okay? Okay, so let me change to number 4. Okay. So now, if you see here, we have the first rib here, which is usually much smaller, and it's more cranial. Now, Daniel, can you please put it on the trapezoid, a wide scan, which is your field of view? Okay, we can make the field of view slightly wider here. So let's do that. Okay, so now this is an extended field of view. Okay, so you can see it's slightly wider, but there are a lot of artifacts here. But I can go back to the ordinary field of view. Right, so you can see that we can achieve a wider field of view, but you can see that's some artifact. So I need some more gel, please. Okay, so let's look at the first and the second rib. And then if I count distally, you will see the third rib will appear, okay, the fourth and the fifth. Okay, so accordingly you can count from, so this is a count down method. So you can count down from the first rib to more distally, okay? So as opposed to counting up, you can also count from the 12th rib and count your way upwards. This is more useful. I usually use that if I'm doing a lower thoracic. I count from the 12th rib and then count my way up. But I never count from L5, S1 and go all the way up. As I said, it's really not very important to be very precise about T9 or T10. It's more important to say, is it upper, mid, or lower thoracic? So that's the first take-home message. Second is, I'm going to perform the scan somewhere in the mid-thoracic region, okay? And you can see here that the transitional anatomy I will show you as we come from a lateral to medial direction. You can see the ribs are more lateral. You can see here, we are scanning at a lateral, just below, somewhere near the scapula. You can see they are very rounded. You can see the pleura is very clear. It's very sharp. In fact, the intercostal muscles are very clearly defined. And as you go more medially, they become smaller because the transverse process will appear here. Now you can see it appears like a small cliff with a slight dip. The rib is anteriorly, and you can see the transverse process here. And this is probably where most people would do their erector spinae plane block. But now look at how the pleura is less sharp in this area. You can see at the intercostal space, the pleura is very sharp and clearly defined. But as you go medially, the pleura becomes less defined, right? So in order to, now this is the midline where I'm palpating my finger. This is the midline, and we are pretty much at the medial part of the paravertebral space. So in order to see the pleura clearly, as I alluded to before, slight tilting the probe outward. If you can see here, we are tilting the probe slightly outward, and you can see that the entire ligamentous complex becomes much clearer. While this improves your visibility of the pleura, but I think the challenge is the visualizing the needle can also become more challenging because you have a slight oblique tilt to the probe. So so this is one of the things that we find may be a hindrance when you're doing a paravertebral injection using a sagittal approach. But I think proponents who use this can get very good at it. But this young man is relatively slim. You can see that the transverse process is only about 2 centimeters from the skin. So in individuals with slightly bigger body habitus, it may be quite challenging. And when the ribs become more anteriorly, as in some of the thoracic spaces, then this space can become very limited. In any case, can be a useful site for performing paravertebral injections with low complications despite the limitations that I alluded to. Okay, now once you've identified the space, let's take a look at the anatomy for epidural injections. Okay, we're going to, can I try your other transducer, the other linear transducer? So we're just going to change the transducer to maybe a slightly lower. We don't need such high frequency. That was 15, so this is also 15, but with a slightly smaller footprint, which makes the image also smaller. So we use the MSK preset. Yes, thank you. Right, you can see here, and now we need to increase the map or gain. What is the frequency here? Put it on general. Okay, general. And you can, no, the depth is okay. I think it's a very dark image, so I need to make it a little bit. You can go to the map. Don't increase the gain all the time. The map, grayscale map, yeah. A little bit more, brighter. No, go back. Yeah, okay. That's where you're seeing the rib. Okay. Then you can go to the transverse process. And as you can see, ladies and gentlemen, that even with good systems, sometimes visualizing the lamina can be quite a challenge using just the linear probe. So while the linear probe is quite useful in some individuals, it may not really fit the bill for every patient, as you can see here. So I'm going to switch over to my favorite, the curved linear probe, and I will show you the rest of the anatomy. So the take-home message is the linear probe, yes, it is a higher frequency, it's free, it should give you higher resolution, but sometimes the penetration and the image resolution that you get is quite limited. Now, the curved linear probe gives you extremely deep scanning, but you don't have to utilize the entire depth. We can actually reduce the depth. You can reduce the field of vision or the field of scan, so you can eliminate some of what you don't need. Okay, so, all right, so can you, right, the depth seems okay. Can you increase focus? We don't have here. So change the map a little bit. Okay, that's better. And then we can, what's the dynamic range you are using? I'll reduce it a little bit. Oh, okay, good. That's a little bit more contrast. Good. Okay, so now, first of all, I'm going to show you the same thing with identifying the ribs, okay? You can see here, it's very clearly visualized, okay? There's no doubt that's rib number 1, rib number 2, you go caudate, rib number 3, rib number 4, and rib number 5. So if you want to do it between rib 4 and 5, you can, at this level, you can identify it, put it in the center of the image, and then you can palpate the space that you feel in the midline corresponding to that level. Okay, so you can place a mark here. This would, in majority of the time, this would be 4 and 5. So, but does it really matter 4 and 5 or 5 and 6? In my practice, it does not. So anyway, we have found that. Next is, I'm going to show you the paravertebral anatomy. So we are going to come from the ribs. They are more rounded. The pleura is very clearly visualized. And as we go medially, the rib becomes smaller. And then now you're seeing the costotransverse articulation. There we go. You can see there's a slight hint of a dip there. And then the pleura becomes less clearly visualized. And we are going further lateral till the transverse process is now seen. So at the true paravertebral space, you can, or at the very medial part of the paravertebral space, which is about 2 or 3 centimeters lateral to the midline, you can see the pleura is actually very poorly visualized. So often, I wonder if practitioners who perform these injections are actually performing intercostal blocks rather than paravertebral blocks. But definitely when you identify the anatomy, and you can see here that the transverse processes are quite distinctly sonographically appear different from the ribs. So therefore you can perform. Remember, visualizing the needle in the in plane can also be quite challenging. So this is why I tend not to use this approach. Now, I'm going to show you the first the paravertebral transverse anatomy, and then we will go to the epidural anatomy for thoracic epidurals. Okay, like so. We are going to do the scan at the mid-thoracic level. For your orientation, the orientation marker is to the top left, will represent lateral. So any transverse scan you see, that'll be lateral. And obviously anything closer to the probe is superficial. So I'm now going to place the probe transversely, and we'll offset it so that we are seeing mostly on the right side. As you can see here, Ranjit, can you focus down there? Yeah, very good. Now, the orientation marker is lateral here, okay? Now, in this case, you can see here, we are seeing the first window. Now, in this case, you can see the tip of the spinous process. Can you help me, Ranjit? You can leave the camera. Just can you put the pointer for me, please? Yeah, Ranjit, you just use this trackball. Yeah, you use the trackball. So that's the spinous process you can see there. Okay, the lamina you can see, which down here, yes, and the posterior directed transverse process. The transverse process directed posteriorly, and then you have the costotransverse articulation. You can see that some of the ultrasound is producing some reverberation artifacts in that area, and then laterally you have the rib. So this is the first window that we want to acquire. If I now slide the probe slightly caudad, you'll see the rib window will disappear, and now the transverse process window, or the Dr. Shibata window, is here now. You can see here the spinous process, and go inferiorly the transverse process, and the lamina in the middle, okay? You can also see through the interlaminar space, we are seeing part of the spinal canal medially. So that is indeed the spinal canal, and you can see part of the anterior complex at that vertebral level, okay? Now, looking at the paravertebral anatomy, you can see the pleura is lateral, which is the hyperechogenic structure is sliding with the respiration. You can also see the thick ligament complex. Actually, here is the superior costotransverse ligament will become the internal intercostal membrane, and the apical part of the paravertebral space is actually just where the arrow is now. You can see there. So you can advance the needle from a lateral to medial direction like so. Insert the needle from here, and then it will emerge like so. And once you hydrodissect and you find your way into that apex, you can inject your local your saline first, and followed by local anesthetic. Now, I would now focus on the third window, okay? Now we come back again. This is the transverse process rib window. This is the transverse process window alone. And now we are going to just go below the transverse process. So now you see the acoustic shadow of the transverse process. Can we reduce the depth? It'll just improve the zoom of it a bit. Okay, that's good. So now you can see the articular process. This is actually that bright structure here. And then you can see the pleura laterally, and the anteromedial reflection of the pleura, you can see part of the reflection there. And then the ligament complex posteriorly, and which continues laterally as the internal intercostal membrane. So this thick ligament complex posteriorly is the superior costotransverse ligament, intertransverse ligament complex. So in this case, if you freeze the image and then use the measurement tool, yeah, and then just show how to do the measurement distance. Just put distance, press distance. No, use tool, use distance. No, I want you to use the, yeah, and then show the needle. Oh, you do it, Ranjit. Put it near the orientation marker first. No, put it where the needle enters. More laterally near the orientation marker. Yes, more towards the skin. Yeah, so the needle would enter somewhere there, enter, and then move it towards move the trackball. Okay, we have some technical issues here. Move it to the edge of the film. Yeah. Okay, right. So now you can see this is where the path of the needle would take. You will see it now enter the apical part, we would inject some normal saline, see distension of the space, widening of the paravertebral space, and we would perform the paravertebral injection. So this is indeed your paravertebral injection at the articular process level. We find this quite objective, and indeed you can see the entire paravertebral space in front of you. You can also see increased echogenicity of the pleura after you inject and widening of the space. So these are all objective signs that you are indeed injecting into a tissue space. You are not injecting into a blood vessel, which can occur as it is quite vascular. Okay, now let's go back to, so this is about paravertebral scan. I just want to show you that the paravertebral anatomy in the lower part may appear slightly different. You will see here the paravertebral space appears much wider. You can see here, this is the one of the lower spaces, okay, probably T8, T9, or maybe lower. So this is your first window. If I go to the transverse process, you are now seeing the apical part of the paravertebral space. You can also see that the transverse processes are much shorter here. As Bernard and Ken alluded to, the transverse process is much shorter. And then if I go just below the transverse process, you see the articular process, and you are able to see the large apical part of that space. So you can see here there's a large, often wider space. If I go to the next one below, you will see the space appears quite large. So I find paravertebral injections in the lower part much easier than when you perform it in the upper parts. But nevertheless, if you follow this, you can, your needle is actually tangential to the pleura, as Dr. Shibata discussed in his paper, that the needle direction is the same. But because we are tangential to the pleura, pleural puncture is rarely a problem because your needle is coming tangential to the pleura. It's not directly towards the pleura, but it's directed towards the foramen. So therefore, one must have good control of the tip of the needle, because if you do not, then you can inadvertently advance it too deep and it'll enter the intervertebral foramina. Okay, so this is about paravertebral windows and how you can perform paravertebral scanning. Now I'm going to show you how you can use this to perform epidural imaging, okay? So you can see here, now we are performing a scan, the same scan. You can see here, this is the level of the transverse process. You can see that the image is exquisite. It's very clear, it's very clean. The muscle in this young man is well developed. You can see the different layers of the paraspinal or the erector spinae muscle. As you go more medially, two things happen. The osseous structure become more bulkier and the pleura starts to become less visible. You can also see there are some artifacts starting to appear. And as you see, this is the paravertebral space. But in the sagittal view, it is quite limited. Now, once we have identified the transverse processes, one could see the articular process sometimes with the facets, but sometimes it's very difficult. So we are now going to do the paramedian sagittal oblique view, as I alluded to before. You can see the lamina are quite flatter than the lamina in the lumbar region, but you can see the acoustic window is quite narrow. But you can see the posterior complex with the ligamentum flavum, the posterior dura, and the epidural space, where the arrow is now. Go back to the epidural space. Just behind that, and the lamina are posterior. And the anteriorly, you can see the anterior complex, and the anechoic space is the intrathecal space, the spinal cord, and chorda equina, etc., which will be there in the lower level. So if I were to perform a scan in this individual, you can see this level is quite good. You can reduce the depth, please, improve the magnification. Yeah, no, not too much. That's good. So you can see here, in fact, now you can indeed see the epidural space very clearly. It's a very narrow space, but nevertheless, the epidural space can be visualized with a thick ligamentum flavum behind. Let's look at the space above. You can also see the posterior dura, the ligamentum flavum. So in this case, the aim is to guide the needle to the top of the lamina, if you may, or the interlaminar space, and then perform your loss of resistance technique. This will avoid you from directing the needle to medial, and therefore potential for contralateral paravertebral placement, or even contralateral pleural puncture. So these are some things that you can very easily avoid. And by advancing the needle in plane from here, you can easily guide the needle to the lamina or to the interlamellar space as you may, and then elicit loss of resistance. Often success on the first attempt is usually much better. So let's show you the upper spaces. The upper spaces can also be visualized, and you can see the upper spaces are sometimes quite wide. As I said, T3, T4 is sometimes much wider than most other spaces you can see here. Before I used to do paravertebral blocks, I did a lot of thoracic epidural at T3, T4 to perform breast surgery. So now you can see the entire upper thoracic window, if you may. So this may be the T3, T4 because it's quite wider in respect. Anyway, so let's take a look at the lower thoracic space. You can examine the lower thoracic spine here, and we go from a lateral to medial. You can see the ribs. We can actually go down and you can maybe find the 12th rib if you want. Yeah, go. So caudal is to your right. So you can see here, we are actually looking at the psoas and the kidney, and we are going upwards until you see the 12th rib. So you can see the 12th rib, and here we go, 12, 11, 10, and 9, okay? So let's go at 9 and 10. So if we look at the 9 and 10 level, you can see the, can reduce the depth a touch for me. Yeah, so you can see the interlamellar spaces. They are quite adequately visualized. The visualization of the interlamellar spaces are adequate. And you can guide your needle and use loss of resistance to identify the epidural space. I think you would agree that ultrasound imaging is not good enough today to tell me when the needle tip has reached the epidural space. Maybe in the future it will. But in the interest of safety, I think it is still prudent to perform the imaging and then use loss of resistance as you would normally do for a normal epidural to identify the epidural space. Okay, so I think we've had quite an extensive discussion. We've demonstrated to you. Let me go to F1. Okay. So I have demonstrated to you the sonoanatomy of the relevant for paravertebral blockade. I've also shown you how you can use ultrasound to identify the anatomy relevant for thoracic epidural, particularly the paramedian. I did not go into showing you the transverse scan because it's not really very useful when you're doing it for intervention. It's used for pre-procedural scan can be useful. So with these viewers, I think I'm going to end the live demonstration. Once again, thanks to VSonic for providing us this equipment for today. And thank you, Daniel, for helping us for the scan. And if there are any questions that the audience may have, I'm happy to answer them. And are there any questions, Rossini?